Welcome everyone to Mayo Clinic Q&A. I'm Dr. Helena Gazelka. 1/3 of the U.S. population will develop cancer during their lifetime. Understanding how cancers develop on a genomic level and developing drugs to target patient-specific unique form of cancer is an approach called precision oncology. With us today to discuss this is Dr. Joel Samadder. He's a gastroenterologist and leads the clinical genomics program at the Center for Individualized Medicine at Mayo Clinic in Arizona. Thanks for being here today.
Thank you, Dr. Gazelka, for having me on the program today.
Well, so wonderful to learn about something new. I'm excited about this. Let's start with one of your recent studies. It spotlighted early onset colorectal cancer. Why do some people develop colorectal cancer early in their lives when we kind of think of it as a disease of older adults?
One we don't have a complete answer for. We know that at least 10% of colorectal cancers occur before age 50. Some of the risk factors for this could be underlying diseases like inflammatory bowel diseases, Crohn's disease, ulcerative colitis, having a family history of colorectal cancer, or a genetic predisposition that is floating within a family. But at the same time, we have found that over the last 20 to 30 years, there's been a rising incidence of early onset colorectal cancer. So much so that in the last 10 years or so, we've seen that the incidence of rectal cancer, specifically in females, has increased by 9%. We don't think this is due to a lack of colon cancer screening, since that was never employed in younger persons. So there are probably other factors, whether that is biological or environmental issues leading to young onset colorectal cancer.
So one of the risk factors is an entity called Familial Adenomatous Polyposis, or FAP. At what age is this rare genetic disease usually diagnosed, and how do you treat something like that?
There are two main genetic causes of early onset colorectal cancer. One is called Lynch syndrome. This is caused by mutations in genes that are involved in DNA mismatch repair and increase your risk of developing colorectal cancer to about 80% lifetime risk. And a number of other cancers are also increased in that condition, including endometrial cancer, small bowel, stomach cancer, several skin cancers, and renal or ureteric cancers. The condition we're talking about with you right now is a second one called Familial Adenomatous Polyposis, or FAP. This accounts for about 1% of all colorectal cancer. It is caused by a mutation in a gene referred to as APC. This genetic condition is autosomal dominant. What that means is if you have the genetic condition, your son, your daughter, your brothers, and your sisters have a 50% chance of also having that genetic condition. Having one abnormal copy of that gene means you have the condition. So that's called a dominant condition. This gene, if mutated, increases your risk of developing colorectal cancer to 100% lifetime risk. So if you have that genetic mutation, you will develop colorectal cancer. There are also a number of other cancers associated with this genetic mutation, including duodenal or small bowel cancer, stomach cancer, thyroid cancer, and then rarely brain cancer as well. But again, the most important one is colorectal cancer, since you're at a 100% lifetime risk of developing it. The typical presentation of a patient with this condition is they'll often present in their early teenage years with blood in their stool or rectal bleeding. That would lead to an evaluation by a gastroenterologist, typically, who would do a colonoscopy. At the time of colonoscopy, you would find hundreds, if not thousands, of precancerous polyps, these little growths in the colon of this individual. Any one of these growths can become cancerous, and usually if nothing were done, usually by the time someone turns into their 30s or reaches their 30s, they would develop colorectal cancer. So what we have tended to do to treat this condition is to perform a prophylactic surgery, which is the removal of the colon, referred to as a total colectomy, usually in their late teens or early 20s. As you can well imagine, such a procedure can be traumatic for a person of that age to lose a major organ or a large piece of their bowel. It can lead to a change in quality of life just as they're finishing high school or pursuing college or a career or other job environment, developing social relationships. And therefore, a thought has always been, can we use a precision approach where we have a medication that can prevent the development of cancer in these patients and either negate the need for this morbid procedure of taking out your colon, or at least delay it till your adult years where you've had more time to make an informed decision and hopefully finish schooling or develop relationships such that you can undergo that procedure.
Your international study on FAP found a potential combination therapy that may help patients with the most serious cases. Can you tell us a little about that?
Yes, our group, along with many other groups internationally, have participated and conducted a number of clinical trials looking at medications or drugs that can delay or prevent the onset of cancer in patients with FAP. This most recent trial was just published in the New England Journal of Medicine, and it used two different medications, one called DFMO or eflornithine, and another medication called Sulindac. Sulindac is a non-steroidal anti-inflammatory drug, so similar to aspirin or Advil or celecoxib that your readers may be more familiar with, but in that class of drugs. And this study looked at using both drugs together or each drug separately in upwards of 150 FAP patients that were randomized or equally placed into all three groups and then followed on average for about 4 to 4.5 years. What this trial found was that the patients who took the combination drug, so both drugs together, had no episodes of disease occurring in the lower bowel or in the colorectum. None of them ended up needing colectomy or excision of a remaining portion of the rectum that's often left in place even after the colon is removed, or excision of a large precancerous polyp in the colorectum. So even though the main study did not show that the drug combination prevented the occurrence of cancer in all of the disease groups for FAP, it did show that in the lower bowel, it seemed to have a marked effect. So future trials will expand upon that group and look at the use of this combination drug purely for the lower gastrointestinal cancer prevention, which again is the most important cancer that occurs in FAP.
The patients who you described who would typically be having surgery, would they receive this treatment instead of having surgery, even if they have polyps, or would this be an additional treatment?
It could be done in both ways. So ultimately, I think as a group of experts in this field, we would like to have a medication that we can apply to young FAP patients. So before they've had surgery, before they've had a large number of polyps occur, so that hopefully we can stave off surgery for years, if not decades. That's one group. The second group would be patients who have a significant polyp burden or even have undergone a colectomy. But often when you undergo a colectomy, they will leave about 10 centimeters of rectum in place that continues to be at risk of cancer development. So this medication could prevent the formation of polyps and cancers in the rectum, decrease the need for colonoscopies in the future for these patients or the need for a second surgery.
So how does doing genetic testing help you help oncologists tailor the treatment of cancer?
That was one of the most exciting things in genetics, I think, is moving from the purely understanding of why you developed the disease to how can we either prevent the occurrence of disease or treat the disease differently. So if I break it into those two pieces, by understanding what cancers, for example, you're at risk for, we can either do intensive screening or even possibly prophylactic surgery. So I'll give you an example of this. A woman who has a BRCA1 or 2 mutation has a markedly increased risk of developing breast cancer. So early on, we may start with intensive screening, including mammograms starting at a young age, followed by breast MRIs. And then at one point, we may offer, depending on the family history as well as the specific genetic mutation, if a prophylactic surgery like a bilateral mastectomy is warranted to decrease the risk of breast cancer forming completely. So that's the cancer prevention realm. In the other group, you have precision treatment approaches. So depending on what cancer you have and the genetic mutation that may have led to it, we may be able to use targeted treatments, things such as immunotherapy or PARP inhibitors that work on a certain genetic pathway. Again, I'll give you an example of this. We have known for several years now that breast and ovarian cancers that are related to an underlying BRCA mutation benefit from the use of a medication called a PARP inhibitor. Well, about a year ago now, there was a large clinical trial that showed pancreatic cancer. Again, pancreatic cancer, which has a very low survival rate. And if it is due to this BRCA mutation, this breast cancer gene can lead to pancreatic cancer, these specific patients actually respond extremely well to that same breast cancer drug, a PARP inhibitor. So we are moving away from thinking about cancers in silos where there's a particular drug for breast cancer, a different drug for pancreatic cancer, a different drug for prostate cancer, to an understanding that, well, there are a spectrum of cancers, breast cancer, ovarian cancer, pancreas, and prostate cancer that may all be related to the same underlying genetic abnormality in BRCA. And if that's true, we should use that same breast cancer drug, a PARP inhibitor, to treat any of these cancers because the genetic pathway that led to them is the same. The Centers for Disease Control actually put prevention measures in various tiers. It turns out that genetic testing for BRCA and Lynch syndrome are placed as tier 1 interventions because of the very high risk of colon, uterine, breast, and ovarian cancer in these genetic syndromes. The feeling is that if we can identify them early on in a person, we have good options for the complete prevention of breast, ovarian, colon, and uterine cancer in these groups. One of the best ways to do that is to uh, cascade from the index person who has the genetic mutation and likely has the cancer at presentation. So we cascade out to unaffected family members to see who's inherited that same genetic tendency or genetic predisposition and try and target cancer prevention to those groups. Uh, Both of these disorders, for example, are autosomal dominant. So if you have that genetic predisposition, your children, your siblings, your parents have a 50% risk of having that same genetic condition and therefore being at risk of those same cancers that we may potentially be able to prevent altogether.
If someone undergoes genomic genetic testing to look for propensity toward cancer, it doesn't necessarily mean they won't develop a cancer because not all cancers we know the genetic link yet. Would that be correct?
About 15 to 20% of cancers are associated with a genetic inherited mutation. So the vast majority, 80%, we don't have a clear genetic cause. It's probably a combination of genes, your environment, and then some amount of bad luck as well. 15 to 20% are highly genetic, where having genetic testing can help clarify your risk of developing cancer. But even if you test negative on a genetic test, you're still at risk of developing colon cancer, breast, ovarian, skin, prostate cancers. And we always recommend that people follow the current American Cancer Society or NCCN guidelines regarding cancer screening. For example, colonoscopy starting between 45 and 50, mammograms starting at age 40, etc.
So it sounds like another very important tool in the toolbox, as it were, to assist along with the screening measures that are already taken.
Not the single magic bullet that will end cancer, but it is part of our toolbox where it will help allow us to modify screening for those at greatest risk, modify treatment for those with a cancer that we may be able to target the biological pathway and provide them with a greater chance of long-term survival.
This is really exciting information, and we'll get a chance to learn more about the work that you are doing at the upcoming virtual Center for Individualized Medicine conference on October the 14th. Can you tell us a little bit about what to expect from that conference?
That'll be really a meeting of the minds, bring together some of the authorities across Mayo Clinic that have expertise in inherited cancer, cancer treatment, genomics of cancer, and truly individualized medicine. And we'll be able to find how these areas intersect to provide the best care possible for our patients.
Thanks to Dr. Jewel Samadder for joining us today to talk about precision oncology. I hope that you learned something. I know that I did, and I hope you have a wonderful day.
Mayo Clinic Q&A is a production of the Mayo Clinic News Network and is available wherever you get and subscribe to your favorite podcasts. To see a list of all Mayo Clinic podcasts, visit newsnetwork.mayoclinic.org. Then click on Podcasts. We hope you'll offer a review of this and other episodes when the option is available. Comments and questions can also be sent to Mayo Clinic News Network at mayo.edu. Thanks for listening, and be well.